Thank you very much, Dr. Treppel. It's a pleasure to be here. I have no financial disclosures. So the objectives for this morning, to discuss the identification and value of plantar pressure and temporal parameter analysis in the insensate foot, to review and compare force data collection systems, to analyze the essential information that's provided, and to offer an illustrative methodology for its application. So Aristotle was one of the earliest biomechanists who in 350 BC described the ground reactive force. And I bring reaction force because I bring that up because he said it's as the pusher pushes, so the pusher is pushed. And that's the whole thing with gait analysis and preventing plantar ulcers. You have to push against the ground in order to have the ground push back and generate a correspondingly equal force. So the ground reaction force is composed of gravity and inertial components. It's affected by gravity and inertial components. And in gait analysis, the ground reactive force can validate the degree of disorder in movement disturbances. So the predominant ground reaction force is vertical, and that's the M-shaped curve, the soft M-shaped curve, first described by Carlet in 1872. And that's the one that's used today, and that's the one that everybody says, oh, there's a heel impact, and then pronation, and then propulsion. In walking, we press down and back against the floor. So there's a posterior horizontal component. And then the floor presses up and forward. So there's an upward vertical component and a anterior horizontal component. And that's the bottom graph in the middle slide. And so that has moderate type forces. The medial lateral reaction force is the least. So foot ulcers, as Dr. Steinberg so aptly described, it's moderate, repetitive mechanical stresses, especially in the horizontal component of the GRF, and is accentuated with neuropathy. Diabetic foot ulcers, commonly caused by repetitive stress in an area subject to high vertical or shear stress in patients with neuropathy. And where do you get the shear stress? From mechanically dysfunctional feet, excessively pronated or excessively supinated. 68% of ulcers don't develop at peak pressure sites. 37% of plantar ulcers occur in the hallux. Now, that's not because of peak pressure. It's because of long, low, moderate pressure applied inappropriately at a time when the foot isn't capable of accepting that degree of pressure, especially in the presence of neuropathy, especially in a devitalized system. So peak pressure, as a general rule, is a poor tool in predicting diabetic ulcers. Skin breakdown occurs faster if shear forces are present, and shear forces are present in excessively pronated or supinated feet. Shear forces associated with keratoses are increased risk factors, as Dr. Steinberg noted, for plantar ulcers. So the idea is to reduce those forces that created the shear, that created the keratoses. Bunching, stretching, and twisting effects generated by plantar shear may accelerate tissue breakdown. And where do those things occur? In excessively pronated or supinated feet. So watching somebody walk is not going to be enough. You can't see under the foot. It's an unreliable indicator of foot function. Is it better than having them sit in the chair? Yeah, because who needs your feet to sit in the chair? And who needs them to lie on your back or on your stomach? You only need your feet to stand and move. And the diabetic, the problems develop during movement. So this depends on the clinical skills of the examiner. And from examiner to examiner, it's varied. So video gait analysis, that's better. It allows documented observation of high-speed events. It provides movement patterns. So you can record all this stuff, slow it down, and it's inexpensive. So everybody that has a camera is now an expert in gait analysis. But you know, there's very few experts. Everyone thinks they are, but there's very few. People in the running shoe shop think they're experts. But it takes a long time to be able to discern problems that occur in gait. Especially video, you slow it down, but it doesn't detect pressure. And it doesn't detect the path of pressure, which is equally as important. And it doesn't easily detect temporal parameters. So computer-assisted gait analysis obviously reveals many more gait abnormalities. This is an instrumented walkway. We have this in the college. So it gives you 3 or 4 steps. The problem is you can only record the force from the bare foot to the walkway or the shoe to the ground, not inside the shoe. It does measure vertical forces, it measures temporal parameters, and it displays the footprints in real time. So this one here is a mat, and that's not as good as a walkway, and it only records 1 step. You have to target the mat. So many times you'll do 15 or 20 walks to get 1 viable bit of information for 1 foot strike, 1 side. So it's better than nothing, and it does record vertical forces. And then you have to do the left side. You get the right foot, and then you do the left foot. So why do you do computer-assisted gait analysis? To assess foot and ankle function during gait, to influence and improve patient outcomes, and to identify limb length discrepancy. Everything works better when it's symmetrical. And it's nice to know if something is not working symmetrically, because there's less stress on the system. You don't want 2 tires, one has a different size than the other, and you don't want them lined up inappropriately. To influence hypermobility, you can identify and with certainty predict ulcer outcomes if you can identify hypermobile segments in the foot. Prevention and management of plantar ulcers, pre and post-surgery, CFO's prescription, and periodic objective evaluation of progress. So this started in 1947. I mean, it was done in the 1800s too, but Harrison Beath in 1947 did a pressure mat that it was just ink. And you could make 1 step on it, or maybe even not a step, you just press off on it, and it records the pressure. And right here you see there's no pressure under the first, meaning that's not stable. There's more pressure under the hallux, 2nd and 3rd mets. But you can do the same thing by looking inside your shoe with a camera and just lighting it up, and you can see there's no pressure sub-first, there's pressure on the hallux, and the 2nd and the 3rd. So there's something going on there. The force plate measures force in 3 body planes, and that gives you everything. The problem is you can't use these in a clinical setting. First of all, they're prohibitively expensive. They're $40,000 each and up. So if you have 1 plate, you have to target it like a mat, and you're only getting 1 step, and you're not getting inside the shoe. You're only getting from the foot to the plate, either shoe or barefoot. And if you have 6 plates, you might get 1 or 2 steps if you're lucky. And that has to be embedded in a walkway, and the connections are tricky. but it measures force in 3 body planes. It's good for jumps, leaps, measuring sports movements, etc. And if you want this information, you send them to a hospital gait laboratory. But even the hospital gait labs, they won't give you what you need. What you need is what I'm going to show you. Since the foot, we know the foot functions in segments, and it has to be in the right position at the right time. So it's critical to assess the direction and amplitude of pressure in a time context, when the forces are occurring, and can the foot handle it? So we want, that's an average stance. This is everything I show you is from a patient, from patients. So we need to have a stability of the foot and ankle determines its ability to accept normal and abnormal forces without it buckling or compensating. And the ability or disability can be clinically, easily, and objectively determined with computer-assisted in-shoe pressure testing. So this one I'll show you in a minute. This is the same right and left of one individual, and there's 2 different functioning feet, yet they're both pronated. So in-shoe pressure testing, and again, I'm not paid by anybody. On the upper left picture, you'll see it's a paper-thin insole, and it's cut to size to put inside the shoe. And that measures vertical forces, provides temporal parameters in a realistic environment. And this was discovered in 1982 by Michael Polchaninoff, a podiatrist, one of the first orthopedic fellows at NYCPM when I was the chairman. And we had him teaching at the college 1 or 2 days a week in the clinic. And when he used to come in, I used to grab him for an hour or 2 to try to distill some of the information that he was gathering and apply it clinically. And it would take a couple of hours to get 1 bit of information out of him. He was a consultant for NASA, and he's still a consultant for big corporations all over the world. And they were measuring the force on astronaut suits at liftoff. And they developed pressure force transducers, 1/32 of an inch thick, that were indestructible. And he said, this is great for gait analysis. Before this time, you had to go to a gait lab. And what did they have? A 4-foot square gait plate embedded in concrete in a walkway that you had to hit it just right. So the only people that went to get gait analysis were people with severe gait abnormalities, not the everyday variety. So he developed this system, and he doesn't get enough credit for it. And this system has evolved, and it was bought by other companies. So 7 sensors in standard positions. And it also measured temporal parameters. So I've been doing this. I had the first one in clinical practice in my office in fall 1982. And I've done gait analysis in the office on every patient with mechanical dysfunction since that time. So I have all that information and all those records. So it's non-invasive documentation of locomotor events that you can't see with the naked eye, or forces that are too rapidly occurring or too small to be detected. It quantifies and records weight distribution, patterns, and pathways. And it sees underfoot. It's repeatable, relevant, and reliable. You can see here the right foot, that's a hypermobile first. How do I know? Because it's overloading second. And you know who first came up with this? Morton. In the 20s and 30s, hypermobile first ray. That was Morton. And then the second is a pronated foot, but the first is more stable because it's able of taking the pressure. So when you select your surgical procedure, you need to know these things. I believe that this needs to be a standard of care. It can be done in the office, and it should be done in the office, especially in the insensate foot. So force versus time. So, and I'm giving you level 1 of the information that's provided. And Dr. Steinberg gave you the introduction. So this is a level 1, and then there's level 2 and 3 of appreciation of how that foot works inside the shoe and how it's moving and how you can change it and how if you did something, you can change it and know what you did if it worked or not. So this happens to be, it reveals the abnormality. There's excessive pressure on the second and third mets. That's the blue and the yellow with the lines, but it doesn't tell you why. The reason why they get that, the second and third most often, they can't get out of the way. The first doesn't do the job. So how do you get the first to do the job? And you need to examine the patient. So all these things are great, but you need to know the background. Like Dr. Steinberg said, you need to do the biomechanical examination. And then the temporal parameters. Everyone knows stance and swing 60-40. And the stance is divided into 4 parts. The important one is mid-stance, where the entire weight of the body presses down on the foot. The adult norm is about 30, up to 30, but ideally it should be 18 to 22. Propulsion, look at here, it's 19 on the left, but it's 25 on the right. So there's either a contracture, a tight muscle on the right side, or a short, functional right limb. Yet the single support is equal, and active propulsion should always be greater than passive. You see active propulsion is greater on the right side than the left side. Passive is lower, and single support is equal, and also initial and terminal is equal. So plantar pressure considerations. All high pressures are not injurious, and all low pressures are not harmless. So if you grind away for a long enough period of time, you're going to wear it away, and then you're going to develop an ulcer. So just because there's red there in that right slide doesn't mean that it's going to ulcerate. International guidelines advocate reducing the maximum pressure by greater than 30% to reduce the risk of DFUs. So how do you know? Unless you know. Evaluating plantar pressures throughout ulcer progression may provide clarity on the relationship between plantar pressure and mechanical stresses. So plantar pressure alone, high or low, doesn't tell the whole story. You need to look at it in context with time. This one here, the top's the left foot, the bottom's the right foot. Look at the difference. The left heel is on the ground versus the right heel. Now, how do you know that? Unless you do this. And measuring limb length is not a criteria for functional symmetry. It has over 90% of the population has limb length discrepancy over ½ inch. And it's usually easily adjusted for. But it's not only the amount of time, it's the amplitude of pressure as well. So it would be nice to know these things. So it's easily done in the office. Cut it, put it in the shoe, connect it to the ankle pack, then it goes to a waist pack. Notice, and then it's a belt. It's very lightweight, ergonomically designed. Notice how it tips to the left side. And then you just watch them walk. You need 25 feet. My office was designed with 26 feet so that I could have enough room to have them walk. And so you go down, and it's remotely activated, and it's fed into the computer. It comes back. So then you get the information. And his stance and swing are equal. But then when you look at his foot flat, I put here, it's not weight bearing really yet, it's just the fifth touches the ground. You see the foot flat is greater right, but the mid stance is greater right also. And his propulsion is a third more on the left side. So he has a functional left limb shortage. So the first thing that has to be done, he's in an orthotic or he's not. If he's in the orthotic, then we need to balance right and left. And if we balance him out left to right, he's going to have less shearing forces going through his foot. The difference from the left heel, and you see the active propulsion is greater on the left side, the shorter side. Yet the single support is equal, so you might not notice this watching him walk. The difference from the left heel to the right heel is 17%. That's much too much. For running, you'd like to get it within 5%. For walking, under 10%. So here's a foot, and you'd say, this is a patient, 62-year-old. I've been treating for 20 years. And it's, well, this is a adult-acquired flat foot. or collapsible foot. He has a high arch foot, seated. So he has a cavus foot, and he stands up, and this is what happens. He has a diabetic neuropathy and CEO of a construction firm. So he has to go to sites, and he goes up and down ladders. He also plays a lot of golf. He has a collapsible cavus, and he has a lot of pseudoequinus influence. So these are his x-rays. You can see there's jamming, tibiotalar articulation, especially on the right, that happens to be his longer limb. And there's more jamming and notch out of the right talus than on the left. Met primus elevatus, he's got sagittal plane compensation with some pronation in there. So he has the posterior calcaneal spurs. He has adequate dorsiflexion, but not adequate for the degree of pseudoequinus he has. He has a spur on the longer side. So this guy has potential for problems. Feet change. You can't do something once and say, oh, I got it. Your foot's going to change. And when you're working on the foot, it should change for the better. But anyhow, this was barefoot 2006 with him. So you have decreased pressure on the first, on both. So that means he has a hypermobile first, increased pressure on the second in the hallux. And he has no pressure in the middle of the foot. Yet you saw the foot, it's a flat foot. Why is that? That's because by the time the middle gets to the ground, the heel has picked up. So the whole weight of the body, most flat feet, when they walk, they don't use the middle. It's the heel and the ball. And in his case, because of the pseudoequinus, he has mostly in the forefoot. So then this is his barefoot test. You see the first med head doesn't bear much weight. What sticks out from the pack is the second and third Mets on both feet. And then you look at his numbers, and the stance and swing are equal, but his mid stance is good. So he's the guy that he finishes the race, and he has good numbers, but he falls to his knees, and he needs oxygen because he's not running another race. It took too much out of him to get these numbers. So this is what you want to prevent from breaking down. And even his heels, the calcaneus is even, one side to the other. His is barefoot 2009 versus 2006. You see the way it changed? So now he's leaning on the left side, and the left is more problematic than the right. And he's got increased pressure on the hallux. And so we look at 2009, the green doesn't even make it to pressure on the left foot. The right's a little bit better. And of course, what sticks out from the pack is most subject to ulceration and breakdown. Anything that's aided by other body segments is less apt to break down. That's the hallux, the red. And it's poor unloading. That's another thing to evaluate, how it loads and how it unloads. Everything should flow smoothly, no bumps and no jostles to the system as it's moving forward. His barefoot the numbers were still good. In fact, very good for him. But again, he pays the price. And if you leave it like it is, then those pressures are going to cause a problem. In 2012, you see those oval type marks in the heel? That's from impact. He impacted so hard that he wrinkles the sensor in that site. And again, you can see the ridges. That's from poor impact. He had poor hip rotations as well. No pressure, first metatarsal. And then unloading is terrible. And then the first med head, better, but the second and third, overloaded. 2019, pressure again on the left side. Those lines, those white lines, that's the path of pressure the body takes over the foot. So they're medially driven. They go middle, and then they start breaking down. Left more than right. So now you look at this, and there's vertical application of force. No pressure under the first met. So it's still much more impactful left side than right side with poor unloading. And then second and third is exposed to more pressure, especially on the left side. So the mid stance is a little more on the right side, and the propulsion 15% more on the left side. Active propulsion is negative on the right side versus the left side. And then the difference from the left heel to the right is 12%. So you need to take a look at that. No person with an insensate foot should be allowed to walk barefoot. Barefoot is never good for anyone. Bad shoes are better than no shoes. And this is him in his sneaker. So here he is in a Brooks sneaker, and see the numbers are much better versus barefoot. The weight distribution patterns are better, one to the other. And you see the width of those feet are much different one to the other. You see the width without an orthotic, and then this is with an orthotic. You see how much narrower his foot is and better weight distribution patterns. He presses off on that first. That's the least effective part of the orthotic. So we go forward here, and again, this is his Brooks sneaker, and this is with the orthotic. Much smoother curves, and the first is much better in function. 2019 Brooks, again, asymmetry one to the other, 12% difference one to the other, and in the orthotics, he's much closer, 25, 21. We ended up putting a lift in here, but I want to finish up with one other person. Brooks, 2022, he put his golf orthotics. We didn't know that. That's why he has pressure under the hallux. He was supposed to have his sport or workout orthotics, which are more rigid, but the golf orthotics allow him to follow through on the swing, so they're more flexible. And he didn't tell me till the end of the test, but there's the difference between his sneaker and with the orthotics. That's his golf orthotics. But he did bring in, this is his sneaker without the orthotics, that's a sneaker with the orthotics, with the overloading of the hallux because of the flexible orthotic. But he did bring in his boots. I'll show you that. His numbers were fantastic, amazing, really. So here's his work boot with his more rigid orthotic, and the forces are much better. So he did have that with him. That's his work boot, and that's his golf orthotic. So now I have the last one I want to show you. This is his work boot numbers. See, you can document your improvement or not. He's a 79-year-old guy, 5'11", 175. I saw him since 1988, and he has a recurrent bone tumor of the right hip. 1975 resected the right ilium. He had a secondary sensory neuropathy of the right limb, and his main problem was gait instability. So this is 2021. You see he has more pressure barefoot on the left side. Easy to see. So this is going to be something that you can't identify unless you have the information. Your perspective is only limited by what your perspective is. So what you're doing everything you can, but you don't have all the information that this would give you to be able to see under the foot. So there's 2021, but there's in his sneaker without any orthotic. And then, so here's his 2021 sneaker. Look at the difference from the left heel to the right heel. And then the numbers, 36 to 15 mid stance, 17 to 32 propulsion. And the active propulsion is poor on the longer limb side. And he's got a 24% difference left to right. In his CFOs with a half-inch lift built into the metatarsal, to the metatarsal heads. So he has 28 and 13, 24, 34 propulsion, and the difference from left to right is now 19%. So then what we did was we added, that's the difference, sneaker, and then the sneaker with the orthotics half-inch lift. 2022, he's more even. See, there's 2021, there's 2022, barefoot, more even function. And then we have CFOs, we put a 3/4 inch lift in, and that's better than before, but there's still a difference from left to right. And I will go over 1 minute. 2732 propulsion, and the difference from the left to the right heel is 15%. So then we added a 1/4 inch insole to the toes on the right side, and that improved the situation. And by doing that, with 21 and 14, and the propulsion was equal, and active propulsion was basically equal, and the difference is 9%. So 9% is livable. He went to the shoemaker, and in September we saw him back, and he didn't like to lift the insole, so he had it built into the orthotic. And they put in 5/8 of an inch from the heel to the met heads, plus the half-inch we had built in. And that's what it ended up with. You would never know this individual had that degree of asymmetry or dysfunction. And that's with the 1 1/8 inch lift, 25 and 20, which are good numbers anyhow, 28, 26, and 16 and 15, and then 52, 52. So you can't beat that. This is what he looked like in June, and this is what he looked like in September. So that's a normal curve. So one to the other. In conclusion, the acquisition of vital, objective, quantitative foot and ankle data in a clinical setting has become increasingly practical and of particular value in the insensate foot. Ladies and gentlemen, thank you very much for your time and attention.